Good morning, and thank you so much for having me here. So, as it is, we are short of time, and a lot of time has already been taken. I'm going to be talking about all the four-legged animals in this table today. And it is smooth moves in pursuit of joint preservation and role of hyaluronans in the knee OA. I don't have any conflict of interest. So we all know knee OA is something that is rampant, more than 650 million people with 86 million added every year. And then it leads to pain, stiffness, swelling, and loss of normal joint function. And it's not just pain we have to bother about. We have to also bother about joint function. And there's another thing we have to bother about. That is joint preservation. So with this, I'll take an overview. Ever since Carl Mayer and John Palmer hit the bullseye to get the hyaluronic acid out of it in 1934, we've come a long way. In 70s, we were using it for the horses to improve the performance. In 80s, we introduced the hyaluronic acid, which was animal-derived, and we started using it, and we called it as a pain-relieving substance. In 90s, we had US FDA approval for hyaluronic acid, and there they were calling it as an intra-articular device. And then finally, in the turn of the century, we had many types of hyaluronic acid coming into the market. So the various types of animals in our stable are growing. And you can't put them in the same bracket. There will be mules, there will be horses, and then there will be race horses. So I'll just like to differentiate between what there is. So these are the common hyaluronic acid preparations on the higher bracket, the ones which I say high molecular weight hyaluronic acid available in the market. We have those which are low molecular weight concentrations in the sense in mg per ml, but if you look at the variability in kilodaltons, it is totally different. If you see the source, again, the sources are different. And if you see the number of injection, the volume of injection, again different. So whenever somebody talks to you about hyaluronic acid, it's trying to say all four-legged animals are same. How can you do that? So coming to the cross-link type, which are the higher molecular weight ones, you have the Synvis one, which is commonly available. Again, it is a rooster comb, or it's an animal-derived hyaluronic acid. While you have another one, which is Durolin in the market, which is very high molecular weight. We are talking about 10 to the power of 15. That's the molecular weight of the substance. Again, bacterial fermentation. So there is a lot of philosophy here, a lot of things that go under. So all, you'll be presented with a lot of hyaluronic acid in the Indian market. People will be saying, okay, this is also 20 mg per ml, 3 ml. But then if you look at it, the molecular weight is much lower in kilodaltons. So they are not all the same. And it's not just high molecular weight. We also have very high molecular weight hyaluronic acid today in the market. And then what is this rheology? We need to understand that you have to distinguish not just the molecular weight hyaluronic acid, you have to think about the rheology of hyaluronic acid, and you have something known as a low shear rate and a high shear rate. Now, low shear rate is that rheology that helps in normal day-to-day activities, while high shear is for impact exercise, so it's a different thing altogether. So most of the hyaluronic acid available in the market have got a very good working function in low shear rate viscosity. They do not do well in high shear rate. So you need something that has got a very good high shear rate viscosity proportion in order to get results. So that is why the variability of the result which you see in the market, in your practice. So you have one which is a very high molecular weight substance that has a very good high shear rate also, and thereby it gives a better result. And then let's look at the prevalent evidence in the treatment of knee OA. We all know that it's a glycosaminoglycan, that's the normal hyaluronic acid. It's about 2 ml in the joint, made by sinusoids and chondrocytes. Biochemical, we understand, mechanically minded, we understand. It's a rheology we are talking about. But then it's not just the rheology. We have to also look at the biochemical properties, and there is an anti-inflammatory process that is happening there. And that is actually the reason why you find the hyaluronic acid working much longer than its supposed action time. So there are a lot of skeptics that say that it only lasts for 24 hours after viscose supplementation in the joint, and how does it work for a longer period? So there is I'll just give one postulation that has been put forward, that there is something known as heavy chain substance that combines with the hyaluronic acid with the presence of TGF alpha stimulating gene 6, and this leads to a hyaluronic acid and heavy chain matrix. Now this has got an affinity to inflammatory cells, and this leads to consistent inflammation in the joint. When you give an hyaluronic acid, this washes off the matrix and changes the milieu interior totally. And thereby you get loss of inflammation and a long duration of time. So obviously it is understood that if you have a substance that has a long retention time in the joint, it will have a better outcome. So this is what happens, that once you put the injection in the joint, it not only is in the joint space, it is on the juxta-articular surface and it penetrates deep inside and covers the nerve endings and thereby gives that immediate pain relief. So I'm not really concerned about what happens immediately or what happens in 6 months. I'll come to that when I take this forward. And then we all know that, we understand that it has got an anabolic effect, it's got a viscoprotection effect, it's got an analgesic, anti-inflammatory. Visco-induction is another thing. It also induces normal viscosupplementation once you give an exogenous hyaluronic acid in the joint. And then chondroprotection. So use beyond knee OA is also something we have to look on. If you're looking at somebody in high impact exercise sport, they could be supplemented with viscosupplementation in order to get better performance and more longevity. And then safety issues. There aren't many. Just local site injection, most usually, pain, which is transient. There is something known as pseudo sepsis, which is very rare and far between. Look at the guidelines. I think Shinoy has really dealt with them in a very short slide. I made a larger one. I didn't know how to really get to it. So what you know is that ACR, EULAR, and even ORCI has brought a lot of conflicting guidelines over the years. Yes, you may not, you may. It's just something like George Orwell's Animal Farm, two-legged bad, four-legged good, maybe this, maybe that. So it's conflicting guidelines because they're pooling results from different molecular weight products, and there's a paucity of long-term clinical studies. So again, Shinoy just presented studies of 6 months and 1 year. So let's look at something which is longer so that we can get a real picture of what's happening. Resulting in lack of confidence in IHA. Thereby, the guidelines are such. And look at the 2019 American ACR guidelines. So they have talked about, obviously the non-pharmacological therapies, which is very important and it's been very well covered by Sir. And then you look at the pharmacological therapies, once again, they've given, contradictory, remarks, and they say that it's conditionally recommended against. Now, what are the conditions? We need to go deeper. So if you look at this, most of the studies they have considered are in English language and before August 2018, and there's a lot of studies which has come after that. Again, they only considered studies in English language, right? See, a lot of literature is there in, Asian languages, in Chinese language. I remember when I published a paper in Shanghai, they published it in Chinese. We couldn't find it after that. So there's a lot of stuff there, and there are a lot of bias, blinding procedure, comparators, sham alternatives, short durations of RCTs they have considered. So obviously they will not be able to infer the right thing. And then look at the conditions. Preconditions they've excluded. Common conditions where I would like to prefer viscosupplementation instead of telling this patient to go for a TKR or something is patient with hypertension, coronary artery diseases, severe serviceability, transportation issues, cost issues, then mood conditions, and again, patient acceptance. If patient says no to surgery, it is no. You cannot force that patient. You have to give them an alternative. Sorry. Yeah. And then, in conclusion, what have they said? Now, they said conditional recommendation, all right. What is the conclusion? These guidelines provide direction for making treatment decisions which may be viewed more favorably than offering no intervention. So that is what we need to read. And then could be used with shared decision-making protocol, and then it should not be used to limit access to therapy or even insurance issues. So basically they're saying use it. Okay, now what is the world saying about it? Now this is a compilation of 25 guidelines all over the world, and we have 10 guidelines that strongly recommend the use of viscosupplementation. 10 have those conditions, NSAID resistance or like NSAID problems and other problems. 2 are uncertain, they don't want to be committing. 2 are, weak recommendations again. And 3 are saying strongly recommending against, because what data they have in their possession, that is how they are making their recommendations. So and we all know that, there's a good study that says that if you do use viscosupplementation, it delays the time for TKR. So I think again, I'll go back to what Shinoy just said. You have to prepare the joint before going for surgery. You can't send a person for surgery with weak knee, obesity, weak muscles and everything, and obviously osteoporosis. You can't do that. So you have to prepare. So you have to bridge the gap between, a person being good for surgery and a person being, starting from where they are. Right, so a personal experience that I've gone through over the time when it was introduced way back in 1998, that's when I started using viscosupplementation and trying to understand over the time how it has been. The first paper I presented was IRACON 2005. Here I was talking that you have to use a multi-dimensional approach. You cannot just think of giving viscosupplementation alone to get results. You have to do patient education, alignment, physiotherapy, joint preparation, and obviously concomitant medication. And then here also we said that it does work. Again, we went to 2006 in APLAR and presented this, where we compared the results of intra-articular glucocorticoids versus viscosupplementation, and we found that it is a very short-lived outcome with glucocorticoids, and viscosupplementation have a longer outcome. Again, 2007 in EULAR, we presented this, which had a similar approach where we were saying that, yes, there is something more than 6 months, more than 1 year we have to look at. It is not just 6 months and 1 year. What are we looking at? Pain, function, we are looking at WOMAC scores. Are we looking at something more? So, yeah. And then in 20, we published this data from our cohort, 15 years longitudinal study. At that time, 1,200 patients, that's what we found in a hurried, gathering of whatever data we could find. And we found that repeated viscosupplementation works, and it gives a long-term result. And then there is a difference between the outcome of very high molecular weight and high molecular weight products. And then repeated injection brings a similar effect. The first injection, the next one also brings a similar effect of duration of, action. And finally, we started doing a full study, took out all the data from my cohort and started evaluating that. And it was a huge data of more than 2,037 patients who had been given a singular type, non-animal derived product only. We were not mixing the types of products because we didn't want any bias in that. But then we differentiated very high molecular weight and high molecular weight in this. And in this study, we saw that about 75% patients were having justified outcomes, with WOMAC scores improving more than 30%. And once again, we were looking at very high molecular weight showing a better outcome compared to high molecular weight. And the responses were sustained beyond 12 months. Now then, the final study, which this whole thing came about, we call it the HAVOC study. And first, I presented in London in IOF this year, and then it went on to the CASM conference in Niagara Falls, and then in COA, Canadian Orthopedic Association conference in Canada, in Halifax. So I presented this paper, and what it says is that we have primary objectives to determine long-term sustained effects of viscosupplementation and different types. And then secondary objective was to see how long does it work. And then for shorting of time, I'm just running through, sorry. So we had adult bilateral knee, 15-year cohort, KL 3 and 4. Not 1 and 2, because 1 and 2, I usually don't find them very clinical. They don't come to us with pains. And then treated with non-animal derived products. We looked at WOMAC scores. Continuously, we were doing that. That was my normal protocol right from the beginning. We record that. And we found the difference between high molecular weight, which is 6 to 8 mg per ml, that is a 6 ml injection commonly available in the market, versus 20 mg per ml, 30 ml, that's very high molecular weight. We were looking for primary responders and sustained responders who sustained respond more than 6 months. And in 2,037 patients, we found that 75% patients had a primary response to treatment, which is very good, which justifies therapy. And then again, we could see here, in the primary response, there was no major difference between the different types of viscosupplementation. Just a mild difference, 75% and 70%. So this is where we are misled. And then we went on to the, normally we found that it's similar across intervention type, gender, and grade of osteoarthritis. But the sustained responses,
Dr.
the ones who responded,
one more minute.
The ones who responded for more than 1 year was, here the difference was getting markedly there. Less than 70% in high molecular weight and more than 85% of the primary responders in very high molecular weight. And further, if you look at the interval, the time, the duration of work, so this is how we calculated. We looked at the first injection and the third injection so that we could calculate the effect of 2 consecutive injection, in order to remove bias, outcome bias and all that. And we found with very high molecular weight, we got a 5.67 years response for 2 years, 2 injections, and a 1.95 for high molecular weight. So there's a vast difference here. So, and then there are studies which say that minimum clinical important difference between the various products that are being used for, osteoarthritis are there. So when you look at where you club the hyaluronic acid, the difference is not enough. But when you differentiate between high molecular weight and low molecular weight, there is a vast difference, and high molecular weight works and low does not. So this is something you have to differentiate. You have to find out which is the mule. You have corticosteroid there. That's the mule in the stable. But then you also have, that's the beast of burden. But then you also have race horses. The one which you want to bet on is high molecular weight versus the low molecular weight. So here we are. And for this, my take-home message from the study, we know that there's conflicting non-committal guidelines that is creating a lot of havoc around. Our study compared various types of viscosupplementation and molecular weight. Overall, 75% result obviously is something that's worthwhile. Primary responders, 75%. And then of that, we had about 80% patients who sustained the response. And then there was a vast difference between very high molecular weight and high molecular weight viscosupplementation. So take home what I want to say is every patient is not the same. You cannot, you have to tailor make prescription as per the patient, as per their desire. A lot of things, a lot of factors are there. And just a small algorithm of how I go about things and what I think is the best way forward. When I get a patient of severe OA, obviously if there's synovitis, I'll be probably thinking of the mule there, and I'll be reducing the synovitis, getting the inflammation out, and then try all other methods. And then in such cases, most patients are offered a TKR when they are in grade 3 or grade 4. In such conditions, you have to look for patient issues, unwilling, unaffording, early age, comorbidities, and medical issues. So these are the patients that should be given a bridge therapy along viscosupplementation. There could also be treatment issues like lack of facility, unfit for surgery, treat the active disease, make the patient fit for surgery by muscular exercises and weight reduction and osteoporosis management. Again, this is where you use viscosupplementation to bridge the gap. And this is where we can take this forward. Thank you so much.